Hi, I'm Dr. Jan Potter and I'm here to introduce the REACH Toolkit. This is a resource to help staff identify the signs and symptoms which might indicate that we're approaching the late stages in dementia. Advanced dementia is also known as end-stage dementia or severe dementia and is characterised by progressive neurological deterioration which results in cognitive and functional decline, and it's irreversible and is currently not curable. Approximately 50% of people who are diagnosed with dementia live in residential aged care facilities. Some are in low-level care, some are in high-level care. Literature reviews have shown that up to 40% of late-stage dementia patients undergo burdensome or inconvenient or uncomfortable investigations or interventions during the terminal phases of their illness. We also know that advanced dementia has a similar long-term mortality to severe end-stage cancers, with up to 70% of advanced dementia patients dying within 6 months. There's been numerous research studies done showing that when we educate and resource our aged care facilities so that they can meet the needs of their advanced dementia patients towards the end of life, we actually reduce emergency hospital presentations, and very interestingly, we improve quality of life for patients and carers and actually reduce mortality in the nursing homes. In our local area, we've done a lot of pilot work and we've found that many of our aged care facilities are still feeling the need to send patients into emergency departments, and that very few of our facilities are routinely using advanced care directives or ongoing life management forms. And this is because of a number of different reasons which we hope to try and address during this DVD. We know from the literature worldwide that when patients have end-stage dementia and they go to unfamiliar environments such as emergency departments or being moved around different hospital wards, this significantly increases distress, and it also results in a higher mortality for that patient group. We know that the process, end-stage dementia, is not curable and is a terminal illness. But when we look at our own facilities, we realise that there's many different contributors to the fact that we continue to send patients into the emergency department. So how can we move things forward? What we first want to do and foremost is to improve the quality of life and the evidence-based medicine that's practiced in our facilities for our advanced dementia patients. We want to do this by facilitating carers and staff's ability to recognise when a patient is developing end-stage dementia, and then to recognise that they now have an opportunity to plan ahead and to interact with families and carers to adopt a more holistic course rather than reacting by sending patients into emergency department, and to allow the planning process to allow that facility to then look after the patient in their end stages. We're doing this using the REACH Toolkit. REACH stands for Recognise, End of Life and Care Holistically. The project has been running for a year, and the whole idea of today's talk is to point out the literature review results which show the symptoms and signs which indicate that a patient is approaching end of life. These are that the patient is becoming increasingly dependent for simple activities of daily living, so they'll be requiring support from somebody else for washing, dressing, toileting, etc., etc. The patient may develop severe impairments in communication. This can range from expressive and receptive dysphasia to simply not communicating or talking nonsense. Then there's a whole variety of different eating and feeding problems, which might be a difficulty in swallowing, an inability to eat, a disinterest in eating. So any of these can also be a trigger. Mobility problems are the next identified feature, and this can be as simple as increasing falls, loss in ability to walk, but ultimately would progress onto not being able to hold yourself upright on a chair or in bed, and ultimately developing contractures and being completely immobile and bedbound. Persistent confusion, agitation, apathy, withdrawal, behavioural symptoms are the next indicator. And these are indicators which we often find are not recognised as meaning that somebody has advanced dementia. And these are an important group to be aware of. Recurrent infections also. And each of those 8 features which I've just outlined have all been shown in the literature to be associated with the end of life and dementia and a very poor prognosis. So we hope that people will be able to see these simple triggers and use that as a point to initiate a change in care. We've also put on our guideline that you should consider some of these problems if a patient has, for example, recurrent admissions to the emergency department. Within the literature, we haven't identified that on its own as an indicator of improved worsening mortality. But if you look back at the reasons why a patient is coming and going from the emergency department, you're quite likely to find that some or all of the features we've already outlined are the cause. These symptoms are often present in patients in the last 6 to 12 months of their life. And in this situation, what we hope is that by simply providing this education and realising that these symptoms are part of your patient or your client's group and presentation, that you will then take that opportunity to be able to consider initiating end-of-life discussions and planning. This doesn't need to be a formal process and will vary from facility to facility in terms of how they want to do this. It might involve GPs, it might involve care management staff, it might be done simply by the carer themselves initiating the conversation. The whole aim of developing the end-of-life plan is to look at developing which symptoms you want to treat in which particular way. This can be difficult. Often in end-stage dementia, a patient may present simply with agitation, when underlying that they may have pain, they may have psychological distress or fear, or a mixture of these. And within the REACH toolkit, we've provided various different rating scales and treatment guidelines to try and support you through that process. So the processes that are already being used in facilities vary from facility to facility. Some facilities are using what we know as the ongoing life management form, some have end of care plans, some have other local documents of their own. And the idea is that the toolkit provides us with a way to recognise which patients are approaching this phase and who we should be trying to initiate some sort of documentation and plan for. I'm going to show you now in these slides some of the documentation which we've provided, but not all facilities are using these. Some will have their own documentation. This GP advice summary sheet, which is shown as an example from our Shoalhaven facilities, outlines a simple way within the notes and documentation for the patient for you to identify which symptoms you've recognised, to document what conversations and family wishes have been discussed, and to provide your local GP with a summary of the processes that have gone on so far for that individual, and also to allow this form to be used as a referral form to include aged care or palliative care advice if required. Many of the facilities which we've visited during the project have also outlined that they at times have difficulty getting immediate support when a patient is in distress or they're not quite sure how to proceed. The local contact page, which you can see now, actually gives contact numbers 24 hours a day where aged care or palliative care services can be available to support the facility. That outlines what we're hoping can be achieved and can be improved. We recognise that there are lots and lots of challenges, and not every patient will simply fall into a neat little box. So the sorts of challenges that we regularly face are difficulties in nutritional support. Many patients, when they stop eating, families feel very concerned that the patient is being starved and are very keen that you would pursue nasogastric tube feeding. This is a common problem and it's a very emotionally charged issue. In fact, the literature around this area shows that each of these artificial feeding interventions do not prolong life or quality of life for the end-stage dementia patient. And simply by encouraging families to know what the natural course of the illness is and to know what helps and doesn't help can often help to alleviate anxiety. We recognise this won't work in everyone, but we're hopeful that we can improve the general quality of care for the majority. On this slide with common challenges, you see the different areas where it may not be possible to move forward. And as I've said, the whole aim of the project is to try and improve the education and resources so that the majority of cases achieve best practice care within the facility. On this page, we look at some of the common symptoms and signs which a patient may present with and some of the simple treatment options. And again, it's really about a shift in the focus. It's not about identifying treatments that will prolong life and maximise function. It's simply about identifying symptoms that are distressing to a patient and often distressing to families as well, and looking at what simple ways we can alleviate that distress. We also have included some other guidelines. This guideline looks at sedation for acutely disturbed elderly patients with behavioural problems which are causing distress to the patient or the carers or indeed other clients within the facility. The most common neuropsychiatric symptoms in advanced dementia are agitation, depression and withdrawal and lethargy. And within each of these there can often be psychotic features and symptoms in addition. The literature looking at this area unfortunately shows that many of the antipsychotic medications prescribed to this group are not reviewed and remain there even though the symptoms and signs have changed. And again, by regularly reviewing what's causing distress to the patient, regularly reviewing the medication list, we can often alleviate a lot of the suffering and reduce the amounts of medication. This chart simply gives an outline showing the gradual deterioration in patients with dementia. Not all patients will conform to a very gradual slow decline. Some patients have intercurrent illnesses which cause an exacerbation or cause the patient to decline more acutely. But this gives an outline of the general stages and functions and activities that patients are able to do in the different stages. So the features of adopting a holistic approach or a palliative approach are not that we're withdrawing care, more that we're shifting the focus of care. We continually need to follow up what's causing any distress, so all symptoms causing distress need to be continually reviewed. And the emphasis on any treatment is to improve quality of life rather than prolonging life. The literature has shown that when this is applied, we hugely improve the patient's dignity and we improve quality of life, not only for the patient, but often for staff members and family members. There are still numerous challenges in trying to deliver this effective palliative care to this patient group. One of the key problems is that families, clients, and patients themselves, in addition to care staff, often don't realise that we are approaching end of life. And hopefully by recognising and reading the toolkit and identifying the 8 key features, we will help with that problem. It's often difficult to identify who will be the important decision maker for a patient, especially when the patient themselves is unable to participate in these discussions. Many of their carers are also very elderly, may be deceased, and may also have cognitive impairment. Lack of support is also been identified as a key problem around skills in initiating end-of-life discussions. This is an area that many medical, nursing and other staff simply don't feel skilled or trained in. And in the next part of this presentation, we hope to try and identify some of the skills which can help in this area. So the challenges for all professionals in dealing with advanced dementia is to be able to constantly assess the patient and identify what's causing distress, identify what might be a hidden symptom such as pain, to be able to manage those symptoms in a way which focuses on symptom control and relief of distress rather than prolonging life and prolonging symptoms which may actually be treatable in a much more simple way. And communication skills with the family and with other carers in order to facilitate them understanding the progress of the condition and improving the quality of life for the patient themselves. So if we move on to that, communication and patient comfort are really the key areas that we can modify. Ultimately, we would hope that we would be able to manage our patients within the aged care facility. This perhaps within individual facilities might mean changing the way that we provide care, having different areas for different stages of the illness, etc. But again, this varies very much from facility to facility. And ultimately, we would hope to improve patient care with less acute interventions, less burdensome treatments, less trips into the emergency department, and overall an improvement in quality of life. Thank you.